Dr. Alvin Gupta, for your kind words. It's an absolute pleasure to be here, and I want to personally thank Banshi and Shashank for inviting me. And it's great that we are having this meeting, and it looks like a great meeting with a great program and some very good international speakers and great speakers from India. So thank you very much. So today, what I'm going to be talking about is has been a slightly difficult topic about trying to give some practical tips of setting up the obesity service. Now, the reason I got a bit excited about speaking about this topic is just to give you a brief background. So the first time we actually set up this clinic in the UK was probably more than 2 decades ago. And the idea of setting up this service actually came to a great colleague, mentor, and now Dean of Warwick University, Professor Sudesh Kumar. Sudesh came up with this idea that we should be having an obesity service. At that time, people didn't really think it was really feasible because we didn't have any medications, and everybody thought that if you had a high BMI or fat or obese, it was down to your own fault and you don't really require a medical intervention. And to make things easy or difficult for us, we also tried to involve a surgeon at that time. And there were very few surgeons who were trying to do any kind of a bariatric work. But we were able to convince a vascular surgeon to join us in the team. And what I'm going to be sharing you today is our experience of more than 2 decades about how we started the service and how we have run it. And it is more of a personal thing, and I'll be happy to take the questions. Now, before I start, let me just give you a brief idea about the place I work and what is University Hospital Birmingham. So in my first slide, it just gave you a picture of the University Hospital Birmingham. It's one of the largest NHS trusts in the UK with a purpose-built building. It is actually spread over 4 sites and has got nearly 4,000 beds. It is one of the largest solid organ transplant hospital in Europe, and we see over 1 million patients in a year. As I said, the obesity service was set up about 2.5 decades ago, and the way the service has evolved was initially we were just treating people who had issues with the weight and wanted to be treated. And the way we have evolved is now we offer what we call complicated obesity management. And throughout this CD, and when we say complicated obesity management, so we are seeing more patients with NAFL and NASH, or waiting liver transplants. We're seeing patients who are having renal transplant and all kinds of complicated patients. Now, one of the things that we were absolutely clear from the beginning, and we have tried to maintain it, was that this clinic should actually be run by the endocrinologist or what we call metabolic physicians. And that has really helped to evolve the clinic and the way things have developed. And we have got quite a diverse population in Birmingham with people from all multi-ethnic groups. And that has also helped us to kind of direct the service to the patients who are needed most. Now, let me come to the first question that we're asking. What are the practical tips? So to answer the question, I'll probably ask this question. Why do we need weight management service? I won't call it obesity service. I'll call it weight management service. And I think this is the central question that one needs to answer before we are going to set up the service. Because what we see is this really funny cartoon actually explains it. So the people who need the most are usually men in their middle ages who are obese, who somehow think that they are not obese, and they have got all the metabolic complications of obesity, be it type 2 diabetes, be it increases of cardiovascular disease and others. But what we normally see is that the service is actually utilized more by women of a younger age who somehow thinks that they are obese. So the question really is, are we running it as a metabolic service or whether we are running as a cosmetic service? In the UK, the data, because in the NHS, the patients who usually have bariatric surgery have got a metabolic cause. But in the private sector, what we see is that more and more patients who have the bariatric surgery are of a different kind. So we do more men in NHS and more women of a younger age in the private. So I think it's very important that we have the right population. Now, the other question is, what is happening with obesity? And we all have seen this before, but just to remind ourselves, obesity is rising, and this is the data from Europe showing that it's present in nearly 23% women, 20% men, higher in the UK where it goes up to nearly 25%, is accountable for nearly more than 300,000 premature deaths, and 80% of cases of type 2 diabetes are associated with obesity. And we spend nearly 70 billion euros per year in Europe around obesity and its sequelae. And if you look at the data globally, and we can see that the obesity prevalence has been rising. This is the data since 2011, and it's been rising across the globe in all countries. Now, before we proceed, let us just try and understand the definitions of obesity. Normally, the definition of obesity that is normally used is based on BMI. And we all know these definitions, but there is a very subtle difference, and especially from the Indian context. This is very important to know. So this is some of the work that we have been doing through the South Asian Health Foundation, trying to find out about what is the relevant BMI in a South Asian context. And what we have found is that when we actually look at the patient groups in the UK, where we have got a big South Asian cohort, the mean BMI we get when patients get all the complications of obesity is more around the 35 mark. We see very few South Asians with a BMI of 50 or 40, which is more prevalent in the white European communities. So this is the definition now, which is accepted by Royal College of GPs in the UK, the NICE, and even the International Obesity Task Force. And that shows that the BMI definition in South Asian context should be about 25, and overweight should be 23. But the question remains whether these patients with such low BMIs, whether they do benefit from bariatric surgery, although they carry the risk. And currently we don't know that.
Dr. Hanif, can I please request you to be a little louder? A couple of panelists have requested that they can't hear you well, sir.
Okay, sorry. Let me just check. Can you hear me now? Is it?
The audio is a little softer, wherein your sound is variable.
Is this better?
This is better, sir.
Hello?
Yes, sir. It's better now.
It is better. Professor Hanif, you can continue, I think.
It is better now.
Better. You can continue, Professor Hanif.
Okay. Well, let me just try and switch my mic. Oh. Is this better?
Yeah.
Yeah. So I think so. So one of the works that was really done by my good friend Professor Kunti from Leicester was to try and see what is the corresponding BMI in a South Asian context when you compare to the white Europeans with a BMI of 30, and they came up with a figure in South Asian which was quite alarming of around 22.5. And this, we actually followed it up to see what would be the relevant BMI in a much more wider cohort of a population. And again, we find that when we look at the sequelae of obesity, especially around type 2 diabetes, the South Asian population seems to have a much lower BMI than when you compare to either white Europeans or even Afro-Caribbeans, suggesting that the sequelae of obesity in an Indian context happens at a much less. So as we can see over the number of years that even Santa has become obese. So what are the obesity complication impact of weight loss? So if you see quickly, obesity tends to affect almost all the systems in the body, be it right from pulmonary to dermatological. So it's not only about cardiovascular disease and diabetes, it is much more. And especially NAFL and NASH, which is again in my area of interest, is something that is rising, and I see a talk after mine trying to cover this area. But one of the other important points to remember is the body mass index and incident diabetes, and this is the data from the woman, which actually shows once your BMI goes to above 35, your risk of adjusted risk increased by nearly 93-fold. And similarly, especially in Indian context, what is important to understand is not as Professor Mohan was mentioning, not the weight when you were born, which is small, but the weight gain you get, and especially the weight gain around puberty or post-pregnancy. These are the risk factors that increase your risk. Now, whenever you're talking about obesity or setting up the obesity management service that we're going to talk about, it's not only about weight, it's more than the weight, it's the metabolic sequelae. Now, one of the metabolic sequelae that we are seeing more and more is obstructive sleep apnea. And this can have quite a serious effect, both on the quality of life and also in the terms of long-term mortality and morbidity. So an assessment of the sleep in terms of the clinic is very important. Similarly, cancer and the risk of cancer with obesity is something that has been recognized and is important to remember. And finally, one of the complications that is rising, especially we are seeing a lot in our unit, is the number of patients developing NASH or NAFL-associated cirrhosis who are requiring liver transplant. For the first time last year, we did more liver transplant in patients with NASH than we did with ASH, which is the alcoholic steatohepatitis. And this is becoming quite a big issue and will require an assessment in terms of the metabolic management. So as we can see, when it comes to mortality with obesity, this paper from actually shows the risks that are involved. So what happens when you try and lose weight? And we have seen this data from the DPP, which showed with lifestyle, if you lose weight, you decrease the risk of developing diabetes. And this is a kind of a meta-analysis that look at the intentional weight loss and mortality. And it shows that almost in most of the studies that intentional weight loss helps you to live longer. And this just gives you a benefit of nearly 5 to 10% weight loss, having a positive effect on type 2 diabetes, cardiovascular risk, blood profile, blood pressure, sleep apnea, and general quality of lives. So in the first part of my talk, sorry, my slides are moving without me touching. I don't know why. So in the first part of my talk, I actually try to give you an idea about the need for developing the service. Now, what I'm going to try and do is to try and explain about how to run the service. Can somebody help me with my slides, because they're moving without me touching them? So one is the poor infrastructure. So one of the challenges that we have about the weight management services is what happens in terms of the availability. So we have got what we call the primary prevention, we have the secondary prevention, and we have got the tertiary prevention. Now, the challenge that we have got with this is that when we look at the primary prevention, it's about small changes to lifestyle. And this is something that can be delivered out in the community. The secondary prevention is mostly around the weight reduction groups. And the weight management services that we try and run from the hospital is around the tertiary prevention, which is planning the treatment and treating the complications of obesity. The primary prevention is mostly through messaging in the social media, be it TV, health promotions, and it's a more of a public health thing. Secondary prevention is something that needs to be done in the community, in the primary care, which is screening, detection at risk groups and offering the services. And then we come to the tertiary prevention, which is the role of the medical professionals or experts in trying to run the disease. And this quote from Hay, long time ago, explains that the importance of measuring it, because once you measure it, then you have to try and treat it. Now, one of the keys of running a good weight management service is what I call a multidisciplinary team. Weight management services should never be run by a single doctor or a single medic or a single consultant. And I feel very strongly, and this we have demonstrated by what we have been doing in the UK in some of our own clinics, is this multidisciplinary team should be run by or led by an endocrinologist or metabolic physicians, and they should have others, be it hepatologists, bariatric surgeons. They could be pulmonologists who can come and advise, and they could be cardiologists, but it should be led by metabolic physicians. Now, there are some centers across the globe and even in the UK where bariatric surgeons run the service, which is fine. But the only difficulty is that there is always that urge to do the bit extra without taking the whole concept in place, because obesity itself is a very complex disease, and therefore it is important that the metabolic physicians involved. But along with it, you need dietitians, you need clinical psychologists, because some of these patients need support of clinical psychology services, and then you have got physiotherapists, specialist nurses, and others. So what is very important is to have a multidisciplinary structure in terms of trying to run the clinic, which is more of what we call a hub and a spoke model, where the hub can be based in a secondary institute where tier 4 service of bariatric surgery can be offered. And then you have got the spokes, which are out in the community where patients can be seen and advised about diet and healthy living. Now, the question is how to achieve weight loss. Now, the way that currently the treatments that are available, at least I have restricted myself to what is available in the UK, is there are three aspects of the treatment. One is lifestyle intervention, which is basically dietary, physical activity, and psychological support. And then we have got the pharmacotherapy. So the two licensed drugs currently are orlistat and Saxenda, which is liraglutide 3 milligrams, and then there is bariatric surgery. The very low calorie diet, and this is the data from Roy Taylor and Mike Lean from UK, which has shown that if you give the patients 800 kilocalorie diet and follow them up for 12 months in a primary case setting, you can achieve weight loss, and that can have a huge beneficial effect in terms of reversal of diabetes. And they show that if you manage to lose about 15 kilograms of body weight, then nearly 86% of the diabetes can be reversed. So we know that diet works, and we run a special centers for very low calorie diet, or what we call the LCD clinics. And this involves seeing the dietitians, following a liquid-based diet for about 12 weeks in order for them to reduce weight, and then introducing back the food gradually over a period of a couple of months. And the success rates of the LCD and the VLCD clinics has been quite huge. These are the NICE guidelines 189, and I find them very useful, because what they really tell us is how to manage obesity. And as you could see, they are based on two factors, BMI and waist circumference. And for various BMIs and waist circumference, including comorbidities, things are done. So whether it should just be lifestyle, or whether it should be lifestyle and drugs, or whether lifestyle, drugs, and surgery should be considered. And this really helps us to kind of individualize the treatment to the patient for the right treatment. Now, one of the important points to really understand is when it comes to the effectiveness of weight loss intervention, I think there is a difference, and there is a difference depending upon the type of the patients that you actually choose. And this systematic analysis actually shows that the mean weight loss in men is about 7 kgs, and in females it's about 5.3 kilograms, clearly showing that there is a difference between genders. Now, when it comes to drugs, so when it comes to obesity and drugs, since time immemorial, I think medicine has been trying to find treatments for obesity, and as you could see, we have almost tried everything, and in most cases failed. Currently, the drugs that are available, as said, is orlistat, which is there, and the liraglutide 3 milligrams, which we have used in a number of patients, and we can see that the weight loss we get with it is reasonable, and the scales trials across in obesity, diabetes, sleep apnea have all shown a mean weight loss of nearly 82%, 8 to 10%, which is very good. Bariatric surgery is perhaps the best known treatment, and we can see that it is associated with sustained weight loss. The best we get with gastric bypass. Most patients we do is gastric sleeve, which tends to get about 25% of weight loss. Banding, we are doing less and less, and the weight loss we get is quite less. Now, coming back to the point that which is the best treatment or which is the most ideal treatment for obesity, as I said to you, although bariatric surgery is offered in most patients, over a number of years, we have started seeing more and more new therapies that are being trialed. We are involved in trials with oral semaglutide. We are involved in trial with what they call the tricoagonists, which is a GLP, GIP, and glucagon, and a number of these drugs. And the initial data that we are getting is quite encouraging. So in the next few years, we will probably having more and more drugs to run this service. So the question is weight loss difficult? So although we have got all these services, why do we patients still struggle to lose weight? And for this, the reason I usually give a lot of people is that the way we have evolved over a number of millions of years is that we have always evolved in what we call a calorie deficit environment, where there was not enough food around for us. In the last 60, 70 years, for the first time, we are in what we call a calorie-rich environment. So the bodies are not made to live in a calorie-rich environment. So the default position of the body is always to gain weight and eat more. And to understand this better, if we just look at the obesity systems map, the key enablers, and what we really find is you get this. So it is a very complex issue, which is beyond what we call the individual. It is the effect around media, education, technology, and everything is working to make us bigger or to make us fatter. And when you try and make somebody lose weight, you're fighting against all these systems. And therefore, it is very important for us to understand that obesity is not down to individual eating less, but due to a lot of factors that contribute. And this just gives you an idea of the complex systems that are involved in terms of our dietary intake and weight gain. The other big issue is that even in the patients who manage to lose weight, one of the big challenges is maintenance of weight loss. And this meta-analysis actually shows that even at the end of the day, when you lose weight, maintenance of the weight loss is very difficult. And the reason for that is it is quite easy to lose weight. And this just gives you a brief idea about, if you're you need to jog for an hour to reduce 500 calories, and just eating extra slice of bread for a year will put on a stone in weight. And this just gives you an idea about the amount that you need to do to shift just a little bit of extra food that we are going to eat. The other thing that complicates things is that once you start losing weight, you start getting more hungry. And this is some of the data which actually shows your hunger response increase to weight loss. And it shows the more weight loss you have got, the more hungry you get. So the body tries to make you eat a bit more to compensate. So if you look at the physiological response to the weight loss, as we start losing weight in the gut, the GLP decreases, the CCK decreases, the PYY decreases. These are the three hormones, as we know, that control our appetite and stops us from eating. And ghrelin, which is one of the most potent appetite stimulants, tends to increase gradually. The insulin secretion decreases, leptin decreases, the desire to eat and hunger and desire to eat actually increases, and energy intake goes up, and we start doing less. What has also been shown is that once somebody loses weight, especially with drugs, having what we call a weight maintenance thing, where some of the medication is continued for a longer period of time, actually helps you to continue losing weight. So one of the big challenges that you have when you're trying to set up a weight management or obesity service is what I call barriers to raise obesity with the patients. Now, these barriers are there out in the community, and they have to be addressed. One of the major challenges that we have got is we have got a limited understanding of what is obesity care. There is a lot of concern about the negative consequences of it. It is considered to be quite a sensitive topic. So most physicians or even healthcare professionals find it difficult to engage or discuss with the patient. There's always this concern about damaging the relationship with the patients. And we always try to follow what I call the patient's agenda, and you don't challenge them enough. From a patient side, there's a lack of motivation. Everybody wants to lose weight, but they're not motivated enough. There's always the issue of the money part of it. And the interventions, at least the ones that we had so far, did not have a lot of effectiveness, and therefore people are not willing to really engage. And there is a lack of overview in the public health around health promotion and weight loss. Now, what we've come up is this thing which might help for all of us to play an important role. One is to helping patients to understand the causes and consequences of obesity, conveying the risk, be it in form of Q risk of Birmingham calculators, signposting appropriate support which may require referral, trying to treat obesity along with complications, and most importantly, providing a holistic approach. So this is a kind of a framework which we have developed with the question, which is being used, what we call the 5 A's framework, and it is ask, assess, advise, agree, assist. And this is quite important in the context of obesity. It's about raising the issue of obesity, assessing the obesity, its consequences and its sequelae, advising the patient what can be done, agreeing the management with patients being on board, and finally assisting the patients. And these are the top 10 tips from the Royal College of General Practitioners. And this is what they call the safe phrases to use. Things like, how do you feel about your weight? Do you keep an eye on your weight? We know weight can affect safety of doing an operation. Has anyone talked to you about weight? When did you last weigh yourself? Have your weight changed over the past few years? And finally, this has come to my final slides. There's a lot of work in the UK that's been done by my good friend, Professor Partha Kar, who I gather is going to be speaking later on. And this is about the language. The language is very important when it comes to weight management or obesity services. Therefore, it is very important that we engage as healthcare professionals and use the right language. And this is one of the all-party parliamentary group on obesity which did the survey. And they found that a lot of people with high BMI obesity feel they are being stigmatized or body shamed, both in the community and in the wider media. And therefore, it is very important to address this issue. So in summary, Mr. Chairman, what I would like to say is that obesity is a core of multiple medical problems. It requires support to achieve weight loss through a multidisciplinary team, which I feel strongly should be led by a metabolic or endocrinologist. Don't delay pharmacotherapy or bariatric surgery if patient is not achieving target weight loss. Primary care plays an important role in signposting the patients and treating the cardiovascular risk factors, but need resources. And always remember, obesity is a chronic relapsing disease that requires a lifelong treatment. Thank you.